We are thrilled to have Dr. Jen Saigal. She's a neurologist and a palliative care physician. She received her medical degree from Penn State College of Medicine and then moved to Ann Arbor for training in neurology. She then left us, I don't know why, and went to Rochester, New York to complete an additional year of training in hospice and palliative medicine with specific focus on providing palliative care to patients living with neurological illness. I don't have my glasses, sorry. For the past year, she's been caring for patients in the Neuro, Palliative, and Supportive Care Clinic in Rochester, both learning from and providing support to patients with Parkinson's disease, Lewy body dementia, ALS, multiple sclerosis, and others. She recently moved back to Ann Arbor, and she is starting a neuropalliative care clinic for patients living with neurologic diseases at the University of Michigan. So we're thrilled to have her at Michigan Medicine, and we are thrilled to have her here today.
All right. Hi, everyone. Thank you for having me today. It's really an honor to be here to be able to talk in front of all of you. And I'll be around after too. I'll stick around if anyone has questions after the presentation. And so I'm going to be talking about palliative and supportive care today. So some of our learning objectives. Talk a little bit about what these terms mean. What do we mean when we say supportive care? What is palliative care? I know palliative care can be a black box. Not a term that everyone's familiar with, and so I'm happy to go over that with you today. How is that something that can be useful for someone living with Parkinson's disease? And when is it that you might want to see someone who specializes in palliative care? And lastly, I'll also talk about how do we differentiate what palliative care is versus hospice, because they're not one and the same, and I wanted to talk a little bit more about that with you today. So what is palliative care? I'll talk about it in 3 different ways. So palliative care is the idea that we want to help patients live as well as they can for as long as they can. And if there's one thing you take away from our discussion about palliative care is that physicians and other providers who provide palliative care for our patients, our focus is on improving quality of life. And that's the key focus of what palliative care is referring to. And our hope is to, in doing that, trying to reduce suffering for patients that are affected by a serious illness. And overall, practically what that's going to look like and what I'll talk more about is an extra layer of support that helps with symptoms and the stress that can come along with having a serious illness. Now I want to talk about what palliative care is not. And I think this are some common misperceptions that I hear from patients who I'm meeting for the first time in my palliative care clinic. Palliative care is not giving up hope. We always have a hope for a cure. We always have a hope for better treatment options, better research, and recovery. And palliative care can be delivered simultaneously while treatments are being pursued. Palliative care is not the same as hospice, and so these are 2 parts of what I do in my job, but they are separate, and so we'll detail that today as well. Palliative care is often brought up for patients who have cancer, and this is because a big part of how the field was founded was in the care of patients who were diagnosed with cancer and have a lot of symptoms as a result of their illness. But we now know that palliative care is also useful across the spectrum for anyone facing a serious disease. And so it's not just available in our cancer center, it's available to patients across the board. Yeah, did you have a question? Oh, for sure. Can you guys hear me okay? Is that better? Okay, sorry. Please raise your hand again if you can't hear me or if anyone can't hear me, okay? And I want to make it clear too that palliative care is not only for those who are at the end of their life. So this is going to be across the spectrum of one's life. What does it look like to have a team of palliative care professionals on your side? So that might be a physician like myself. It may be a nurse practitioner or a physician assistant, maybe a social worker, a nurse, and a pharmacist. And this is typically what our team of palliative care doctors looks like here at Michigan and at my team in Rochester. Some clinics might also have a chaplain, and especially given how important spiritual and religious backgrounds are important in who we are and how we live. It may be involving a psychologist for emotional support, a physical therapist for physical support, a nutritionist to make sure that our symptoms of Parkinson's that affect our swallowing and our nutrition are addressed. Palliative care may or may not include home health services depending on the program. Bereavement services and community partners can also be involved in providing additional palliative care support, like the Parkinson's Foundation, who has a lot of great resources on palliative care on their website, a lot of webinars on their YouTube channel that I think are really useful to explore. Now, what is a palliative care specialist doctor? So I'm a palliative care specialist doctor. I'm also a neurologist. And it's a specialist doctor just like any specialist that you might see otherwise. So you may see a cardiologist, you may see a kidney doctor if you have kidney issues. And those are doctors who have done general training in medicine, but then have gone on to seek additional training in the heart or the kidneys to be able to provide that care for you. A palliative care doctor has done the same. They've done general training either in medicine, I've done it in neurology, and then spent an extra year or two doing a fellowship, learning about how to provide palliative care and hospice care to patients living with serious illness. And so that care is covered just the way that you might see a specialist by your insurance. It's not a program that you enroll in, it's another specialist visit. And so I often have patients who ask, is it something that I have to sign up for or that changes all of my care? And the answer is no. It's just another specialist visit that you can have that's in addition to the care that you're already getting. So if you're referred to a palliative care specialist by your doctor, you'll have a visit with a palliative care doctor in clinic. It can either be virtual or in person, and I offer both in my clinic, as many doctors do. Usually our visits are long, or we have that space to have a longer visit if needed. So it's 30 to 60 minutes usually at a time. And it could be as often as every 3 to 6 months, could be as little as every year. And some patients I've even seen every 2 to 4 weeks if we really need to meet often to make sure that they're doing as well as they can. So we have that flexibility in palliative care where we're able to see patients a little bit more often, more quickly, sometimes that they might otherwise be seen. Now, you can see a palliative care specialist at any point in your disease after your diagnosis. And so this is not something that you have to hit a certain point in your disease to meet a qualification for. You can ask your doctor anytime for a referral to a palliative care specialist. And you can continue to see your neurologist and your primary care doctor. So those are not people that you would lose. And so what does a palliative care specialist team do once you get to that visit? What might that look like? The big picture is that we're trying to provide a space to discuss a roadmap for the future. I remember I met one of my first patients in clinic who had lived with Parkinson's disease for about 12 years. And I remember him and his wife telling me, we've had Parkinson's, we've been dealing with Parkinson's for 12 years now, but I've never really talked about what the future might hold. And this is the first time I've really had a chance to sit down and explore that with a doctor. And not everyone wants to do that right away. A lot of people will say, I want to take things day by day, year by year. I'm not ready to kind of talk about the future. Others say, I want to know up front what to expect. Right? What are the next 5 years going to look like for me? What about the next 10? What about the next 15? And how might I plan for my future? And so that visit, I think, was a helpful visit for that particular family in just kind of setting a roadmap for the future and being able to do that with a neurologist, maybe who wasn't their primary neurologist, but setting away a special hour separate from talking about medications just to talk about expectations. And so that's one of the services that a palliative care team can provide. It can also be a place to turn to during stressful times as unexpected symptoms come up, difficult situations that might arise that are related to your Parkinson's disease. For advice, big or small, our door, once you're established as our patient, is always open for a phone call, for getting a visit maybe in between the 6-month follow-up you might have with your neurologist, to just kind of talk through some situations that you might be dealing with. And so this is pretty a common situation that I ran into in my clinic as well. We'll also help assess and treat symptoms. So we'll prescribe medications for things like pain, anxiety, fatigue, and others that I'll talk about. We want to help support care partners. They're a big part of your medical support team, your emotional support team, and we always want to include care partners in our conversations. So I've had many visits with families over Zoom where we have 3 or 4 family members joining in, some from out of state, who want to be a part of the care team, and so we invite them to join, ask questions, with our patient's permission, if that's helpful. And so it can provide a space for longer conversations with the whole family and help planning for the future. Yeah. Talking about supporting your emotional and spiritual needs. We had a chaplain in our clinic at Rochester, and I think right now most of our chaplain services are inpatient. I'm hoping in the future that we'll have that as an outpatient as well. And that was a key part for many of our patients, having that additional support from someone who understood Parkinson's disease and also understood the importance of spiritual and existential distress that can come from having a serious illness. And then I will talk about the word hospice here briefly, but a palliative care specialist can help decide when hospice might be appropriate. And that's one part of what we do. And so this is just a model of, again, we have our patients, we have our, your neurologist who's prescribing your medications, and along with you for this journey, we have our outpatient palliative care team that could be a part of your care, and then also your primary care doctor. And the goal is for us to all work in conjunction. Now I'll talk about the 5 pillars of palliative care. And so we've talked a little bit about the last one here, referral to a specialist. But there's, and I'm going to go through each of these in a little bit more detail. So we're going to talk about assessing and managing symptoms, again, supporting emotional and spiritual needs, supporting care partners, advanced care planning as well. So I'm preaching to the choir when I talk about this, but we know that Parkinson's causes more than just trouble with movement and walking. So when we think about motor symptoms is referring to maybe slowed movements, tremors, stiffness in your arms and legs, problems with your balance or walking. That can primarily is what most people think about when they think about Parkinson's disease. But we know that Parkinson's can also lead to what we call non-motor symptoms. So symptoms that are listed above here. Trouble with swallowing. Doesn't affect everyone, but can be a symptom of Parkinson's. Trouble with your gut. Not normally thought of to be due to Parkinson's, but very commonly seen, and something that needs to be addressed. Cognitive impairment. So not everyone with Parkinson's disease has cognitive impairment by any means, but it can be a part of the disease process, is important also to address. Anxiety and depression can happen independent of Parkinson's, but can also happen as a result of Parkinson's disease. Loss of smell, which impacts our taste and our quality of life, ability to enjoy food, and issues with our sleep. And so we recognize that Parkinson's disease is more than just the physical mobility, and we want to make sure that people's quality of life is addressed by making sure these symptoms are not forgotten and treated when they're able to be treated successfully. And this is just another way of looking at this. So again, not everyone has these symptoms, but over the course of someone's life with Parkinson's, we know that it can affect the body head to toe. And this might be a little small to read. I don't expect you to read all the small font, but gosh, trying to show the point that patients with Parkinson's, I've had family members tell me, gosh, I talk to others about Parkinson's disease and they don't quite get how much this can really impact someone. You tell someone I have cancer or I have ALS or Lou Gehrig's disease, and people tend to understand how severely that can impact someone's life. When you talk about Parkinson's disease, I think there's not as much clear understanding of how much this can impact someone's life, and it's different for everyone, and it doesn't impact people on such a short time scale the way that cancer and ALS does. It's more of a chronic illness, but we recognize that there is a lot of symptom burden and care that we need to pay attention to so that we can help our patients live the best life that they can. So people might ask, when can I start receiving palliative care? So I showed this picture here because a lot of times, and we've looked at the research at patients who've gotten a Parkinson's disease diagnosis and what that was like and what they wished was different. And people describe saying it was like, I didn't have a roadmap. I didn't know what to expect. Kind of feeling like you're in a cave and not knowing where to go next. And that first day, I can only imagine how difficult that is. And the concept of palliative care is that we want your doctors and our team, if needed, for support to help navigate, even at the time of diagnosis, if things are feeling like a black box, if the roadmap is not clear, and to help provide a little bit more insight as to where things could be headed. And so palliative care could start as soon as a time of diagnosis, if that's helpful. And it can also start at any point in the disease as things change. This diagram here is not meant to be specific to Parkinson's. It's just a kind of depiction of how things can change throughout someone's illness. But the point is there's no right time to start palliative care. And it can be a support for you and your family at any point in the illness. And to talk a little bit about our next bubble, the supporting emotional and spiritual needs. One of the things I talk to about my patients a lot in clinic is, this has really changed my relationship with my family, my partner, my mom, my children, and I'm not really sure how to navigate that. And creating some space and time to have those conversations, I think I've seen that be useful, even if it's just a space to vent and to let out some of that guilt, some of that frustration that might be coming up. I've had patients ask, I have someone who, my loved one, who I feel like I'm not doing enough for. They're spending most of their day at home, and I feel like I don't know how to support them. I don't know if I'm doing it right. And I usually, at least for this particular patient I'm thinking of, realize, gosh, they're doing so much, they don't even realize it. From medication management to helping with their appointments, sticking it through with them on the tough days, and providing that framework that, gosh, we are taking care of so many patients with Parkinson's disease, and not everyone has that love and care and support that we see in front of us right now. And I remind patients they're doing more than they think. Family members, they're doing more than they think. And so we have those frank conversations in clinic and try to address some of that guilt and burnout that can come with caregiving. There's social isolation that's felt by everyone in the family, and it's potentially felt by everyone in the family depending on where you're at with your illness. And so trying to find ways to address that, whether that's through community partners, making sure that we're aware of what the resources are, getting connected with support groups, a lot of what we do in clinic is also some of the legwork. It's already hard enough sometimes dealing with the condition day in, day out that, let us do some of the hard work in getting you connected with where you need to be. And then I have people who want to talk a little bit more about the future in terms of, their existential distress of why is this happening to me? How did I get here? I was completely healthy before this. I did everything right. Why me? And some of those questions are really difficult to grapple with. We don't have all the answers, but again, we have a space where we can start exploring some of these important questions. And so I think when we talk about palliative care and serious illness, it can be draining. I think it can be something that people want to avoid when possible. Palliative care is something that I think can be a tough term to hear and to approach for a lot of patients. And I guess I want to just put a plug in for our team of physicians and nurses and social workers. We're here right there with you, looking for sources of hope and joy and meaning. We want to help find also ways of finding meaning beyond the disease. So as much as we want to talk about your illness and care for you, for your Parkinson's disease, we also want to find ways to affirm life, reclaim joy, continue to find sources of hope, because you're more than just your disease. And so that's a key part of what we also do in clinic, and that Erin will be talking about later too in her session on advanced care planning, of how do we find what's most important to you, what makes you you, and trying to live as well as possible with the disease. I have, thinking back to a patient of mine who said, I go to the support groups and I talk a lot about Parkinson's almost every day, and I think about it every second when I wake up. And the moments when I'm able to kind of forget about it and just be myself, I'm grateful for those. And she would come to clinic maybe every 4 to 6 weeks, and we would talk about things other than Parkinson's disease that brought her joy. The cruise that she went on that she was not excited about because it was different with how immobile she had become, but how excited she was to still take advantage of some of the beautiful moments in life with her husband. And so I think it's important to remember that this is again all about improving quality of life beyond the disease in the way that we're caring for you. Okay. Talk a little bit about advanced care planning as well. So I'm not sure how familiar people are with this term. It's a term we use a lot in the medical world. And I'll kind of read this first sentence here, but this is kind of how we're referring to it. A process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences about their future medical care. And for some, that might involve things like a durable power of attorney, choosing someone who's a trusted individual to make life decisions for them in the event that they can. But that's just one part of it. So we all have a sense of what we like to do, how much control we like to have over things, what our goals are for our lives, and what we're hoping for. And some of that can change with illness over time. And so when we think about advanced care planning, we want to take some of that personal sense that you have of yourself and of your goals and apply that to how we care for you, and to be able to do that in the best way possible. So we might ask questions like this to help plan for the future for your medical care. What brings you the most joy and meaning in your life? I ask that to every single patient that I meet in every clinic. And that's a key part of getting to know them and who they are. We also then talk about future and kind of what's on your mind. When you think about the future with this illness, are there things that you worry about? And how might that impact what's bringing you joy and meaning in your life? What do you want from your healthcare so that you can live well? And not everyone has an idea of what they want. And so part of our job too is taking what you've told us about what brings you meaning and joy, and maybe even giving some advice on what healthcare could look like to make that possible. And then what do you hope to avoid? This is a big question that I ask all my patients as well. I have patients who are very clear, who may say, I don't want to go to the hospital if I can avoid it. Or, I don't want specific invasive procedures like a feeding tube. And others may say, that would be acceptable to me. And having these conversations in advance can be helpful so that we're not confronting them during a time of stress. And so having these conversations is what we call advanced care planning. And part of my job is to make sure that we at least offer the opportunity to those who feel ready or feel like this would be helpful in planning for the future, to have these conversations in a dedicated space where we're not talking about medications or other things, but just have a good 30 to 60 minutes to help plan. And again, Erin's going to have a great talk later that I'm looking forward to talk a little bit more about what this practically can look like for you too. So we talk through, most of the pillars of palliative care at this point. I'm going to end with talking about hospice. Now, I know some of you may have had experience with hospice, whether it was a family member, or someone you knew. But I want to kind of just make sure that I distinguish palliative care from hospice. So palliative care, like I've said, is a support that can be provided at any time during someone's illness. Hospice is a benefit that's available, it's an insurance benefit that's available to patients who have a life expectancy of less than 6 months. And people often say, well, if you're going to hospice. And hospice is not a place necessarily. It's a service that helps people as they're approaching the end of their life. And that can be provided in a variety of locations. And that can be at home with the support of family. It could be at a nursing facility. It could be at a dedicated hospice facility that's freestanding, that's usually supported by philanthropy. And in certain cases, it can be provided in the hospital if needed. And so the idea with hospice is that the hope is to aim for comfort and to relieve physical symptoms with medications, avoid burdensome emergency room visits, and provide comfort without providing as least invasive procedures and interventions as possible. And that's the overall philosophy of hospice, no matter where you are receiving that care. And what this looks like is on-call staff 24/7. That's usually by the way of a nurse who's there 7 days a week. So if you were enrolled in hospice and something came up in the middle of the night, there'd be someone to call. There's usually a doctor overseeing the care for all patients on hospice, and a once-a-week nursing visit that can increase during the final days of someone's life. There's usually home health support about 8 hours a week, which translates to about 1 to 2 hours a day. So that does mean that the daily care of the patient is usually provided by family. There's usually a chaplain and a social worker who's available, volunteers, and things like hospital beds and equipment that you may need in the care of someone are covered by the hospice benefit as well. And so people might ask, well, this is a conversation that I have with patients who are interested in having this in advance. Some may say, I don't really want to talk about hospice until way far out, until it's time. And some want to know a little bit more about it earlier. But I'll often get the question, how do I know if I'm in that 6-month range? Or what are the signs that maybe things are changing for me and my life expectancy is now shorter? And so we'll talk about that in clinic and be able to help answer some of those questions. But usually your doctor, your neurologist, or your primary care doctor is the one who makes that determination with you. And we don't have a crystal ball, but we use what we know from experience and from our relationship with you, to estimate that life expectancy. What if you live longer than expected? I get this question all the time. Do I get kicked out, of hospice? And if your life expectancy at the end of that 6 months is still 6 months, you actually can re-enroll and continue to receive all the benefits that you're receiving. If your life expectancy is you're doing better than we had expected, usually you graduate and you go back to receiving the care that you were receiving before in kind of our standard, clinic visits and such. And you can still take your Parkinson's medications while you're on hospice. And some of those medications, the team usually goes over with you and discusses what's still helpful, what is not as helpful, to help kind of decide what's the best kind of medication regimen for you. And so just to kind of summarize today, palliative care is available and can be a helpful resource for any patient living with Parkinson's or a related condition at any stage of their illness. It's a referral that you can ask for at any time. It can be placed by your neurologist or your primary care physician. And you would continue to have that relationship with your neurologist as you normally do. I happen to be a neurologist and a palliative care doc, but there are also palliative care doctors out there who may not be at the University of Michigan. You may be seeing someone elsewhere. And so a lot of times people will find it helpful to make sure that they have that relationship with both doctors still. Even if you're not receiving your Parkinson's disease care at University of Michigan, we're also happy to see anyone from any other clinic outside of the hospital. And palliative care, again, hopes to improve quality of life and help plan for the future, whereas hospice care is specifically designed, again, for patients with a 6-month life expectancy, and so that's how we differentiate the two there. So I hope this was helpful in providing some concrete information on, again, what palliative care means and refers to, and I'm happy to answer any questions that people may have. I'll also stay until after Erin's presentation if things come up later that are brewing. But thanks again for having me here today.
Does anybody have questions they'd like answered?
Is there ever a situation in which the neurologist, especially in the case of someone who's had a neurologist for a number of years, would perhaps not agree with the suggested palliative care that might be presented?
You mean in terms of if you were to ask your neurologist for that referral and for them not to agree with that referral? Is that what your question?
No, what I'm asking is, has there been any instances, to your knowledge, of individuals who've gone to their neurologist to have a palliative care professional become involved, in which there was disagreement between the neurologist's path of treatment and that of the palliative care?
Yeah, good question. No, in my experience, it's always it has so far been a very positive relationship. I think usually our goal is to kind of be an adjunct to the neurologist. So a lot of neurologists are prescribing medications that are helpful for both, again, the motor and non-motor symptoms. And if we have suggestions on changes, a lot of times we'll actually reach out to the neurologist and say, hey, you're prescribing this medication. We maybe have an alternate suggestion, and we'll communicate with them about that. And so it's usually very collaborative. And so I think as long as you're keeping that open line of communication, the relationship usually works really well. Yeah.
Okay, so is there ever a case in which the palliative care professional prescribes medication that perhaps the neurologist has not prescribed, or changes the mix of meds that are being used?
Absolutely, yes, yeah. So that's definitely a part of what we do. And so what that may end up looking like is your neurologist prescribes a certain set of medications, they always have been, and now you're seeing the palliative care doctor who's prescribing additional medications, and sometimes even takes over some of the scripts if it falls into their purview to do that. And so one example might be management of depression and anxiety. If you're already on an antidepressant or an anti-anxiety medication through your neurologist, but there's been a lot of discussion with your palliative care doctor about changes, they might even just take that over entirely if that feels right, for you and for the neurologist. So that's one example. Yeah. Another one is pain management. So palliative care doctors are trained in prescriptions of opioids as well, which we don't use, for all types of pain, but we do in some cases. And most neurologists don't prescribe opioid medications on a routine basis. So a lot of times that is something that a palliative care doctor will do independently of a neurologist, and usually with their approval. Yeah. Thank you. Yeah.
The points that you mentioned, can they be downloaded or can they be printed somewhere? Everything that you went through on your screen.
Sure, yeah. Laura Summers, she's here. I think Laura is going to be sending out, it sounds like this is being recorded, and the materials will be sent out to everyone who's attended today. Absolutely. And then if you have questions too, I can always be contacted over email. I'm happy to talk anytime. Sorry, I know I could hear you, but just for the recording, yeah.
So,
Yeah.
if somebody wanted to go to you, but they see a doctor, not a U of M neurologist,
Yeah.
you have to have a refer, or could we call you?
Yeah.
It
So.
has to be doctor to doctor.
So usually it's a referral that has to be sent by your doctor. So if you asked your primary care doctor for a referral, they would do a referral to palliative care. And if in the referral it's indicated that you have Parkinson's disease, that referral would go to me by default. So that's usually the process. Yeah. Yep. Great. Okay. Perfect. Yeah.
Does the neuropalliative care department fall under the movement disorders?
So it's actually in palliative care. So I'm both in the Department of Neurology as a general neurologist. So I also see patients who don't have Parkinson's disease, and then my palliative care clinic is within the Department of Palliative Care. Yeah.
Thank you.
Yeah, of course. And I'm currently the only neurologist in our Department of Palliative Care, but we're always hopeful for more. Yeah.
I'm not sure if you want to address this now, but you mentioned some of the common symptoms like sleep and issues. And
Yeah.
is there any magic like sleep?
I wish I had a magic wand for everything, gosh. But no, I think it just depends on what the specific sleep issue is. And then, there's certain medications that we use to address each specific sleep problem. And so, for example, REM sleep behavior disorder, very commonly seen in Parkinson's disease, has a very specific treatment plan. And then, so sleep it's so complicated. I'm happy to talk more about that with you, but I don't have a magic wand, but I'm happy to help brainstorm and think through that. Yeah.
Do we have any other questions? Okay, perfect. So thank you again for speaking with us today.